Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady Rahban, and boy, do I have a show for you. I am joined today by Dr. Towfigh, world-renowned. Usually I just throw that word around because it sounds good, but she's actually world-renowned. Like she actually has traveled the world talking, discussing, teaching about hernia surgery. She is the a go-to for hernia, laparoscopic, robotic, any kind of hernia. And she's joining me because we had this conversation. We were doing a case together. And actually, I get a text from Dr. Towfigh at least once or twice a week where she's asking me plastic surgery-related questions. And the reason is because Dr. Towfigh, unlike the average surgeon, is so curious about all specialties, but mostly about plastic surgery because of all the train wrecks. It's kind of like watching a horror show for her. And so she's constantly reaching out to me, asking me questions is like, is this for real? And when we were having this conversation, remember, when was it, Shrin? Like a couple months ago?
Yeah, it was last month.
Yeah, she's like, I just can't get over this. People are spending like solid money to look good and they look like shit. I'm like, what is going on here? And I said, you know what? We got to discuss this. And so our topic today is, how do I phrase this? Tummy tucks in particular, because Dr. Towfigh specializes in the abdominal wall, as do I, from the outside and then her from the inside. Is tummy tucks gone bad? Question mark. Why?
Yeah.
Now, the assumption is that people went to Mexico. People paid shitty money. People went to, I don't know, a dentist. That's the assumption. In other words, the other assumption is if you spend a lot of money and go to top-notch people, well-trained, arguably really high-end surgeons, that would not happen. And while there is a little bit of truth to that, that is not the case because Dr. Towfigh and I both practice in Beverly Hills. And we take care of very affluent patients as well as the rest of us normal people. And therefore, this phenomenon of shitty results isn't correlated to money or wealth or access or skill. So she asked me, and out of curiosity and dumbfoundedness, like, what the F is going on? So that is the topic. It's a long-winded introduction. Welcome, Shrin.
Thank you, Rady. I listened to your podcast, so I'm intrigued by this whole topic.
Yeah, I know.
Well, I'm very curious.
You are like a closet plastic surgeon. I swear to God, I get more effing like chisme, which is I think like Spanish for gossip, from you about like plastic surgery training. Did you know so-and-so just got his license taken away? Did you read this article about such and such went to jail? I love it. You keep me in the know because I'm trying to stick my head in the sand like an ostrich and avoid these people like with blinders because I don't want to have anything to do with my own community of plastic surgeons. But you are always bringing, I'm like, oh, yeah, so-and-so did so-and-so.
I feel like I know more about your people than you do.
For sure you know more about my people than I do. I don't want to know about my people because I'm embarrassed. See, like when I would go to a party, I'd be like, oh, what do you do? I'm a doctor.
I know, I say the same thing.
Yeah. Okay, yeah. What kind of doctor?
I'm
a surgeon.
Field.
Oh, okay. Any specialty? Not really. Are you? And then someone like, he's a plastic surgeon. I'm like, no. I'm not a plastic surgeon. It's because like it's embarrassing.
Try telling them you're a hernia surgeon. That usually cuts off the discussion.
I end up showing someone flashing me, and I'm not really interested in doing that with my wife. All right. So, but let's dive in. So the question is, and I'm going to elaborate for you and everybody else. The reason why it's so fascinating that you say this, that is, I see a ton of abdomens. You see abdomens all day long. And I am often shocked, surprised, disappointed as to the results of the abdominoplasties, aka tummy tucks, I see. And the question then that begets is why? And what is why, meaning what has gone wrong? So I divide shitty outcomes as it applies to abdominoplasties in the following categories. And you can chime in on each of these. Number one, the sundial coin slit belly button. that is super round, really large, humongous belly button, or tiny slit-like, narrow-ass, drop a coin in belly button. In other words, a funny-looking belly button. And you don't need to be a scientist to look at someone's abdomen and be like, what the right? So what have you observed in lower belly buttons?
So I think the difference in my practice versus your practice, besides the obvious, is that I see these people 5, 10, 15, 20 years later where it's, oftentimes they look good the first, year or two maybe.
No.
But
they don't. They look like shit from the beginning, and they just continue to look like shit. Like, in other words, if your belly button is made, because we make it, your belly button's made really round and large, day zero. When they come see you 26 years later, it's really large and ugly still. In other words, that doesn't change. They're just made poorly from the get-go. Have you not experienced a lot of funny-looking belly buttons?
Yes. So I saw one. I think I called you about it. It was so small that it closed.
Correct.
And so now you have a closed belly button, but it's still a belly button. So on the inside of that closure is skin.
Yeah, of course. What happens is it traps debris, bacteria. It's a cesspool.
It was so horrible.
And the converse is ginormous, huge belly buttons with an ugly scar around it.
But she was this like chic woman, so fashionable. It comes from a family of multiple surgeons, not just doctors. And she's like, what's going on with it? But I'm like, your belly button was made so small, it eventually closed. And so now it's trapping all that skin that's supposed to slough off inside.
Yeah.
And, I sent her to a plastic surgeon in her town to redo it. And they were like,
you can't redo it.
They didn't know what to do.
No, because what happens is that occurs because something necrosed or died, and the skin edges closed down, and the whole thing has scarred into itself.
Yeah.
So belly buttons. Okay, got it.
The big ones, I would say the big ones, those are at least treatable, right? Because it needs more belly button skin removed, right?
No, not that way. Because what ends up happening is they've cut a large circle in the abdominal wall, and the only way to make it smaller is attempting to do a purse string or some kind of suturing that pulls it in, which actually isn't that effective. I've done it many times trying to correct it. It's a problem that is very untreatable. The next thing that's obvious in abdomens, that's like, what is this? Is dog ears, redundancy. You're looking at the abdominal wall, and all of a sudden you get to the edges of the abdomen, and there's this like weird, funky flap of skin, redundancy, something that adding up. Have you not seen that? Have you not seen abdomens where they got like these little horns or puckering at the corners?
I used to see more. I don't know if people have improved their technique, but what I don't like is when the scar goes below their hip.
Yeah.
On the outside. You can't. What kind of underwear? What kind of swimsuit they're gonna wear or underwear?
That's
a big, wear like boy shorts.
Right. So the big pet peeve of mine is when surgeons track the scar from the pubis onto the anterior thigh. A abdominoplasty needs to track along the inguinal ligament within your abdomen. And whatever the depth or the shallowness of your pelvis is, some people have a deep pelvis, really deep drop. Some people shallow, it follows it. You don't have a choice. But there are surgeons who draw the scar right onto the hip, and then anytime you wear any kind of underwear, it peeks out from underneath it, and you're just like screwed.
So why do surgeons go? Some of them go straight across. I see so many straight across incisions.
What they're trying to do is a surgeon is ultimately trying to create the smallest, shortest scar because that makes the patient happy, and that requires the least amount of work and closure. The problem is this is geometry. Geometry doesn't give a shit about anything other than physics. And the reality is that in order to remove excess skin, you need to excise it in an ellipse. And an ellipse raises in the corners. It goes, and lifts up in the corner. And there is an equal ellipse above it. And as it transitions into the corners, it kind of cleaves off. So it needs to be long enough, about a 3-to-1 ratio, meaning 1 up and down 3, so that when it cleaves off smooth. Something an average, very average tailor or seamstress would know. It's called a dart. In alterations, they call it a dart. In other words, you're taking out excess fabric in a jacket. You don't have a dart to it. Any seamstress or a person who does alteration know this. Surgeons are idiots, and they wedge out this big whack of skin, and then they ended in 8 inches. Bro, you can't do that.
Okay, so I asked the patient, I said, do you know why you had this? Or I've had patients that are planning on having tummy tucks. So I have a discussion with them because I'm always curious, what your plastic surgeon say and where your scar going to be. And this is going to go down here. And I said, well, why? And they said their surgeon told them because they have so much excess skin, it would be a dog ear if they go up higher. Is that true?
No. God, it makes me so frustrated. There's so many wrong things that are being taught and done on a basis. The geometry, it doesn't even make sense. On the contrary, the straighter you go, the harder it is to remove dog ears because the less length you have. The longer your scar, the more dog ear you can excise because you have more distance to dissipate the excess redundant skin. So that's a lie. So we're going to go to the third item that I assure you see on a daily basis. It can't not be on a daily basis. Is hideous, wide, thick scars.
So bad.
Hideous, wide, thick, dark scars. And I'm not referring to keloids.
No, these are such scars.
Unique type of scar that actually seldom occurs. What I'm describing is just shitty work. A keloid could be like, I did the most amazing job and it went shitty. That represents 0.001%. Shitty scars are 30%, which is thick, wide, dark, pulled apart. So you see them.
That's the most common thing I see. I look at the patient because they're like, I have this groin pain or whatever. So I look at the patient and I'm like, oh, are you happy with your scar? I'm like, oh, it's so ugly. And these are people, if I give you names, you all know who these people are. And these are people that would like to wear nicer, skimpier clothing where they're just naked in front of
your loved one. You don't want to dim the lights because you got
they have an issue with, they don't want their husband to see it or their spouse, and they can't wear certain swimsuits, or shorts, whatever. It's super ugly. There are a lot of actresses. So then I asked them. So some of them, it looks like Edward Scissorhands put it together. And I'm sure when they first did it was fine, but I asked them, oh, so how was your recovery? Were you upright the first week? And oh no, I could not stand straight for 3 months.
There you go.
Well, of course not. It was so tight.
So there's three most common reasons for heinous scars.
Yeah.
And I'm not talking about it's not great. Heinous, just, oh my God, what happened to you?
Really ugly, yeah.
Number one most common reason is surgeons removing too much skin. Remember, at the time of your surgery, I can whimsically remove as much skin as I want. I can remove half of your abdomen. All I do is I tell the anesthesiologist, Mr. and Mrs. Anesthesiologist, please bend the bed. And then I go, could you bend some more? A little more. Good. And then next thing you know, half the abdomen is gone.
Yeah.
My patients, every one of them are fully erect. I'm talking fully erect at 7 days. And when I ask them to be bent over, it is purely because I want to decompress the scar for a week to reduce any kind of ischemic reasons, not because of tension. So that's the number one reason. So obviously at some time, 3 months, 4 months, you're going to stand erect. And there's so much tension because you're missing skin that poor little scar is just being pulled into a million pieces.
Yep.
The second reason for just heinous, ugly scars is as you're starting to develop a shitty scar, you go see your favorite dermatologist.
Oh, yeah.
Well, hi, Dr. Schmo. Oh, my God, what is happening to your scar? Let me fix it for you.
Steroids and laser.
Kenalog. Let's start with Kenalog 40 and start injecting this goddamn Kenalog. And next thing you know, oh, my God, what just
that is gone.
A, you just eroded all the surrounding fat, like napalm. B, the scar is thinned out into like paper. C, you develop a shit ton of like vessels and telangiectasias.
Yeah.
And then they're like, well, it's better. It's not better. It's like an inch and a half wide. Oh my God, it makes me so crazy. So that's the second. And the third and most common reason for a heinous, ugly scar is a shitty ass closure. In other words, you got this long scar and, you know, Mario, your tech, is closing. And
I've seen, you know, my problem is I also go on Instagram and I watch these videos because, again, I'm curious. I'm like watching these videos like with a very critical eye. And I see by the time they're done, that skin is so scratched up because it's been manhandled, and not necessarily by a man, by the way, but to the point where the skin is bruised, scratched up. You see little marks of all their instruments. Like when I teach my residents, I'm like, stop grabbing the skin. There's other, like, better. The more careful you are, the less swelling, the less pain, and it heals nicer.
Approximation. So the thing is, listen, when I do my tummy tuck closure, it takes me about an hour on average just to close. Forget anything. I am miserable. I hate closing. Okay? Layer after layer after layer. My fingers are swollen. I hate closing because it's time consuming and tedious. But it is perfection when I am done. No glue, no tape, no nothing. It's done. It was a pain in the ass, but it's perfectly reapproximated. Therefore, requiring the body to generate the least amount of scar tissue to mend the difference. When you see other closures, it looks like literally a dog meat up and down, like up and down. None of the edges match. It'll work itself out.
And they do maybe two layers, maybe 3 layers.
Oh, they'll never do 3 layers. They
2 layers,
2 layers, a handful of interrupted deeps, and a bunch of, and then a running 3-0 or 4-0 running.
You like 5 layers. I've seen you.
So anyway, so those are the 4 things. But we're gonna
get. Let me tell you this. This is like people who have scars on their elbow or their knee. It doesn't heal as nicely as the other because it's constantly bending and it's under tension. Correct. But then when your tummy tuck is being stretched, what I see sometimes is, you know, there'll be a segment, let's say 2 inches, perfectly fine. And there's another segment about 6 or 7 inches, just raggedy and ugly. And now, let me ask you this. How often are those revisable?
They're actually revisable quite often. And there have been hundreds and hundreds and hundreds of patients that have come to my practice.
Yeah.
As long as they are not as tight as a tambourine.
Yeah.
I mean, tight as a like shiny tight. If there's the slightest degree of laxity, you can excise only the scar, not a millimeter of skin, and close it in a layered fashion. And I would say 90% of people do significantly better. If they're as tight as a tambourine, do not touch them. That patient will dehiss and separate, like you end up putting a wound vac in.
Yeah, I've seen that too. Yeah, they go for revisions.
Oh, yeah.
And they're even tighter, and then that whole thing dies. It looks so ugly and disgusting, and now they're even more unhappy.
Yeah, that leads to the last of the most common, and you're going to be like, oh, hell yeah, most common wrongly done, life-altering mistakes of a tummy tuck. Are you ready?
I know what you're going to say, but go ahead.
High scars.
Yeah.
Basically, the scar is like 2 inches in the belly button.
Yeah.
What the goddamn F are you? What do you mean my pubis?
My nurse does that. She's like,
it is now.
Oh, you have to see this more.
That means for the rest of your life, you must wear your undergarments, bathing suits, everything at your belly button. And the crazy part about this is what you do is purely based on patient testimonial and your credibility and your authenticity. What I do should not matter. You go online and you go look at the goddamn work and you're like, wow, that looks like shit. And you don't go. When you go to the average surgeon's website and you look at tummy tucks and you look at the after photo over and over and over again, what do you always see? The after photo, the underwear, is halfway up the abdomen. The before is in the groin showing all the nastiness, and the after is like midriff. Why would a patient wear a midriff underwear in a post-op? Because the scar is halfway up their abdomen.
Well, let me ask you this. Is that their technique, or does that happen sometimes in some of their patients?
No, this is what happens. 100% of the times this is what happens. Even the worst of plastic surgeons know better than to put a scar halfway up your abdomen.
Right.
So they put it in the so-called groin. If you can watch the show, you'll see me doing quotations. So-called groin. No woman who has had 2, 3, 4 kids doesn't have a stretched abdomen plus a stretched groin. The groin is redundant. Your pubis is redundant. Your inguinal ligament is redundant. Listen carefully. So they put the scar in the so-called groin and they mark it. Then they lift up the abdominal wall, do their work, tighten the muscles, blah, 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 bend the bed, remove a boatload of excess skin, listen carefully, sew you together under a lot of tension, and at 2 weeks, 3 weeks, 1 month, 2 months, you will stand straight, and your scar, which is under a lot of tension, will rise up minimum 2 inches because you are missing skin, it was thrown in the trash, and your pubis, your pubic area, is incredibly lax. And your scar gets pulled up because you are standing up and stretch, and your scar rises 2 inches. That's not where they put it. That's where it ends up. When I do a tummy tuck, aside from removing significantly less skin than some of these guys, I put your scar in your groin under tension. I have you hold your pubis, pull it up as tight as you can, and then mark your groin. When you let go, it's like, oh my God, it's in my, like,
so low.
It's on my pelvis. Yeah, but that's not your that's your old pelvis. Like when you finish the tug of war, when the tug of war is done, the resultant location will be much higher than you anticipated. That is why the number one ugly, screwed up, bad outcome is a high scar, because it is so easy for you to screw that up. And then it's a game changer. Even if you have a nice scar, it's still halfway up your abdomen.
But the belly button is so close to it. Don't they figure that part out? Or it's too late? It's more.
No, it's too late. Once you make the cut, it's game over.
Yeah.
Okay, let's take a break. We'll come back and we'll talk about a few items that relate to you and me, which is, why the hell is everyone putting mesh in for their belly button hernias that are not hernias? This is not a groin hernia. This is not a ventral hernia. This is not a incisional hernia. This is a bulge in the middle of your abdomen due to diastasis. You'll talk to me about that because you are the world expert. And then we'll talk about
life after tummy tuck.
Yeah, like timing. Okay, I had a tummy tuck. I want to have a baby. I have a tummy tuck. I need a gallbladder surgery. Like, who goes through there and whatnot? Okay, so let's take a quick break. Excuse me. We'll be right back with Plastic Surgery Uncensored. I'm your host, Dr. Rahban. Welcome back to the second half of Plastic Surgery Uncensored. I am enjoying this banter with Dr. Towfigh, my closet plastic surgeon colleague / world-renowned hernia expert.
We're banter buddies.
Yeah, we are. You get me all riled up. She's like, like kids like to get those toys that they get the toys that they twist up and then they put it down and they didn't get it like the bunny, the Energizer bunny rather.
Yeah.
That's what you do with me. All right, so hernias and abdominoplasties have a great similarity and overlap. As a result, you and I are doing a paper together, which of course you're technically doing, and I'm just adding my name. But we talk about them because I encounter a lot of hernias. Of course, I don't do groin hernias and large hernias, but let's just define hernia. So what is a hernia by definition?
So hernia is a hole. It is typically a hole within a muscle or fascia layer. So it's usually abdominal, although there are other areas in the pelvis and the back where you can get rare hernias. But typically, like a belly button hernia, you've probably seen outie, groin hernias where people have bulges in their kind of lower abdomen, groin area, or surgical hernias where you've had surgery and then now the repair of that layer fell apart and it's bulging.
Right. So essentially, and the key component, this is important for you to understand, is a hole, a deficiency. There's a hole. A bullet went through there. It didn't, but I'm saying. And now there's something missing there, as opposed to something coming apart, which is diastasis.
Yeah.
Muscles were there. They pull apart. There is no hole left behind. There's just a shitty thin layer of, let's just call it abdominal wall, that is holding the contents in, but doing a really crappy job at it.
That's diastasis. Yeah.
Right. So, all right. So where we overlap is a tremendous, I want to say something like 40% of my moms that I operate on, and that's a substantial number, have some kind of bulge within the midline, right down the middle of their abdomen, whether it's in their belly button, which is the most common cause, and or above and below it, which is to be expected. You have this shitty ass, filmy, thin little thing, and the stuff inside, which is almost always just fat. I mean, I don't remember, I've only had 2 patients in 20 years that actually had like intestine. It's always something called preperitoneal fat, just the fat that separates the outside from the inside. And it's poked through and it's got like a gumball or a golf ball size thing sticking out. And when you correct your abdomen through an abdominoplasty, you are going to see that hole in the middle, push the fat back in, and not close the hole or put something on it, because none of that's going to work, because the foundation is this shitty material. You're going to sew the muscles together where they ought to be, and you're going to have the most badass mesh closure, super hard, normal anatomy. And that's the right answer for that condition. What do I notice is that many of my general surgery colleagues, which now are your colleagues, take patients who are two babies, 3 babies in, and go in there and do a major rotor-rooter operation and slap in a bunch of mesh and things like that to fix these midline diastasis-related deficiencies. All of them have failed because they always come back. It's like putting cotton candy and sewing it to cream cheese and using metal to do it.
Okay.
Right? So the metal's not the issue. The issue is cotton candy and string cheese or cotton candy and cream cheese have no integrity. And they always fail. So that's my pet peeve with your people. You don't do that because you're like, this is not really ideal. You need your muscles fixed because you're the creme de la creme of hernia surgeons. But I see that all the time. Why?
So I'll tell you why. First of all, the patients we see are a little different than patients you see. The average person who shows up with a hernia does not have a diastasis. So that's one thing. So we're not used to constantly treating diastasis. And therefore closing and using mesh or whatever technique and not doing any more than that is usually okay. What happens is this other population that has diastasis, first of all, it's a very genetic problem. So we see it in men and women. The men can have it because it's a genetic thing where they're obese or a combination of that. The women can have it because they've had pregnancies and it be some combination of that. So if we look at the obese patient, they never come to you. Or I would say they rarely come to you.
That's not true. I've had patients that were 350 pounds that get to be 185 pounds. I do a tummy tuck, and almost none of them have diastasis.
I understand that. But if they're 300 pounds, they often don't even know they have diastasis because it's not visible or notable. So they go and have a hernia repair. And let's say they do have a diastasis. They don't know because it's not visible. It's not something that bothers them. And the surgeon fixes the hole, which was maybe causing pain, and they're fine. So again, general surgeons are not addressing the diastasis because in that patient, not necessary. But what is important are women that are normal, maybe overweight to low weight. So somewhere between low weight, normal weight, and overweight, but not obese, that have a hernia, and that hernia lives within a very thinned out, spread out fascia or diastasis. In those patients, they are best served if you don't just treat it as a hernia, but you treat it as an abdominal wall reconstruction where you're not only closing the hole, but also using the patient's natural tissue to support that closure, because otherwise they're still going to have that bulging from what you were explaining, which was a diastasis. Though technically the hernia is fixed, but to the patient, they're still bulging, and that's not good.
But that's not only my only pet peeve. So technically the hernia is fixed. I do this, I kid you not, 100 times a month. So every tummy tuck I do, there's always some peritoneal fat. So I shove the fat back in and I close the hole. Those patients who have had that happen before, that hole will split open no matter what, no matter if you use ethibond. They get reoccurrence because that tissue is shit. So the problem is without repairing the muscles, aka a legit abdominoplasty. I have done abdominoplasties in patients with zero excess skin, just to address a significant diastasis, which often has a hernia. And that is the way you get the core back. The problem is if you go in as a general surgeon and repair the hernia in the midline, mesh or no mesh, so whatever, and even go so far as repair the muscle just in that section, you will have a horrific contour deformity because a diastasis begins high and ends low, and the only way you create a flat, uniform abdomen is repair the diastasis from top to bottom.
Right.
Therefore, this is the argument I'm making. With the exception of this subset, everything else I agree, general surgery principles apply, ventral hernia, blah, blah, blah. What I'm arguing, because I see high volumes of these people, when you see a patient who is a postpartum patient, not so much men or whatever, because while it does occur, it's very infrequent, 2 or more babies that has some kind of additional bulge in the midline beyond their diastasis, aka some defect, do not address it in a traditional fashion. They need to be opened up. The hernia hole, belly button has to be pushed in, whatever, and the muscles must be repaired. They are doomed to fail. That's the only thing I wanted to say, because I've seen it fail. And then the problem is when I go to operate on them the second time, my God, mesh around the belly button.
Sutures,
And then the belly button, it starts looking dusky and it almost died because they've gone in through the belly button 4 times because they had to do it twice. Anyways, I mentioned that because you are one of the talking heads within your industry, within your field, and you are obviously, as a result of our paper, we're trying to change that discussion.
Yeah.
So I commend you for that.
And I'll tell you, it's in my population, which is general surgeons and hernia surgeons, it is not being poo-pooed. They're like, oh, we didn't think about that, which is these people don't all need mesh. These people don't all need, let's say laparoscopic hernia repair. There are patients that are excellent candidates for a tummy tuck, like you mentioned, that have this diastasis, that have the hernia, and just leave them alone. Send them to your local plastic surgeon or the plastic surgeon, fix the hernia, and have the plastic surgeon complete the rest of the hernia repair by also addressing their diastasis.
Yes.
And our results so far have been excellent. We have, I think, now 4.5 years of follow-up, and we've had 0% recurrence so far in fixing hernias without mesh. Incisional hernia, let me tell you, we specifically looked at incisional hernias because all the studies show you need mesh for those, and we're pretty wrong.
Right. And I will continue to give you more patients. Yeah. I will continue to give you more patients because I see them daily, and I mean every day I do this in the abdominoplasty. It's almost part of my repair.
Yeah, it's not as controversial for umbilical hernias and epigastric hernias, which you see hundreds of all the time. It's really the incisional hernia, which is a controversial one, which is what we took on because we're trying to prove a point.
Right.
So yeah, both the European Hernia Society and the American kind of Society of different surgeons that we've presented our data to have found it fascinating, and we're excited to.
That shows you what we're up to.
Yeah.
Which is we want to change the dialogue within the abdominal world. And, the beauty of it is that someone like Dr. Towfigh, who's at the top of this, can kind of funnel this information down.
Yeah.
I think there's one more subject that quickly we'll touch on, which I think is important. And the reason why these are all unique topics is that you don't have this joint, having a general surgeon who does hernias and a plastic surgeon who does abdominoplasties, and for them not to communicate would be crazy. That's like your colorist and the person who cuts your hair have nothing to do with each other. It's your hair. They had to communicate. So the last issue is you go get a tummy tuck, high five, you look amazing. Now you got to go do some kind of general surgery. You better make sure your general surgeon is fully aware and often in communication with your plastic surgeon, because while we hope you never go through the abdomen again, and we hope that your belly looks pristine till the day you die, there are instances where you got to have things removed. Gallbladder, appendix, colon, hysterectomy. And the world of intra-abdominal surgery is so far advanced that it was 20 years ago. And almost everything can be done laparoscopically or laparoscopically assisted. But there's times you still got to open the abdomen. When they go to open your abdomen, boy, are they going to be surprised.
Or not. Some of them are oblivious, I'm sorry to say.
Well, my point being is that they're surprised and they don't know they're surprised. But I can tell you your anatomy in the midline.
Surprised.
The anatomy in the midline is not the same, right? You've had sutures and plication. And if they only go through the bottom of your abdomen and don't do anything, and then all of a sudden those areas unravel, there's a lot of things. What's the bottom line? You're going to have abdominal surgery after abdominoplasty. Great. Make sure your surgeon communicate. And, Dr. Towfigh will ask me all the time, hey, I'm doing this lady. She had a tummy tuck. What do you think? And she always wants to make sure she does the patients right.
Well, I'll give you examples. So when I see patients, they often do not include their nose job, breast job, or tummy tuck as part of their surgical history. I will see the scar, but, it may not be something that you necessarily tell your colorectal surgeon who is evaluating you for colon surgery. But I urge you to do, because it affects the quality, it affects the outcome from your tummy tuck, not so much the outcome from your surgery. So I'll give you an example. Lady who's had a tummy tuck, then she needs spine surgery. And oftentimes they have to go in the front to do the spine surgery. Now, if you have spine surgery, they need to cut you in the front. Hopefully you have a surgeon that will be able to go through the same scar and not give you an extra scar, right? And be wary of that, because I've seen them just ignore the tummy tuck scar. Even though they could have used the tummy tuck scar. That's number one.
Just as an aside, I was involved in a case last month for a patient who had an artificial disc placed at their lumbar level, and the spine surgeon and the vascular surgeon asked me to be there. This was a very high-profile individual whom I've operated on before. And I did their approach for them through her C-section, albeit longer. And they were originally going to go up and down.
Up and down. Mm-hmm.
And that would have been a deal breaker. So you are correct that if you have this dialogue and you have good physicians, that at least surgeons can try to go through existing incisions rather than create all brand new ones.
So same is true for if you have colon removed, that colon can come out through that lower scar, and so on. So that's one issue. The second is when you have to go through the abdominal wall for all these necessary operations, the surgeon should not close you like they close everyone else, because your abdominal wall has been plicated. It's been closed in 2 layers with permanent suture to give you a certain contour. When they bust that open and they close you normally, now you have a part of your belly which is untouched, which is your tummy tuck, let's say upper abdomen, and then the lower abdomen you have a surgeon who's using absorbable sutures in a single layer and not plicated. So now you have 2 different contours, and you'll be very unhappy because now you need that tummy tuck redone, right?
Yeah, I mean, I think the reality is that, you did a tummy tuck. It's an aesthetic surgery. It has some very aesthetic key components to it. You are forced, because you wouldn't do it otherwise, to do some kind of general surgery. And as a result, you need to try your very best to bring the 2 worlds together. And hopefully you'll have surgeons who are open and willing to have the dialogue. Often the general surgeons don't care. They're poo-pooing the plastic surgeons as if they're insulted.
Yeah.
And often the plastic surgeons are done with you because you've already paid them and they're on their merry way. So, I do think that when you identify good surgeons, they'll be good surgeons throughout your life. So if you like your surgeon, then that means that if and when the time comes and you need them, they'll be willing there to help you, even if it was 10 years ago that you had their tummy tuck or breast job or eyelid. I mean, I have patients call me all the time. Hey, Dr. Rahban, I don't know if you remember me, but you did my rhinoplasty. And now I've got skin cancer on my nose. Can you talk to my surgeon or whatever? I'm like, sure. Yeah, of course. No problem.
Yeah.
I mean.
And then you brought up the whole laparoscopy robotic surgery, which is dominating most of abdominal surgery nowadays and organ surgery. I teach my residents, that belly button is not a normal belly button. That belly button is a new belly button with new skin around it and vessels and so on. So don't just kind of randomly go through the belly button thinking it's a normal belly button, because that's almost always the first incision for these operations is to go through the belly button. So you got to understand to treat it with care and not mess up the blood flow. And number two, the other places where you put the scars, understand, usually as someone who undergoes some type of aesthetic surgery does it not just because they have back pain from their diastasis or skin that's giving them problems. It's also to look pretty. So don't give them ugly scars. If you can hide it, try and hide the scars. And if you can hide it, you taught me this based on I don't know, am I giving you away secrets?
But knock yourself out.
I teach residents, the typical way to close skin is you use an absorbable suture. It lasts about three weeks. That's not adequate for someone whose skin is already super tight, because then, like we discussed earlier, the skin's going to pull apart, and those little 5 millimeter, 8 millimeter scars are going to look really ugly. So take extra care to do longer lasting sutures to take the tension off the skin repair so they don't look ugly when they heal.
So, obviously,
am I doing that right?
Yeah, of course. The reason why we're friends is because you give a shit and I give a shit.
Yeah.
It's just that simple. And each of us has our lane, but our lanes blend. And the beauty of the work that we do and why we're friends for many years is just this exact situation. You can do your thing, I can do my thing. We can both just ignore each other, or we can do things together. And it's just always so much better. So at any rate, I hope you enjoyed this episode. What we really wanted to do was basically highlight. I told Sharon, she's like your hairdresser who's doing your hair, and then it's like, whoa, what the hell is that facelift you got? Because she gets to see all the bad outcomes, right? People come to her and they disrobe, and she sees bad outcome after bad outcome. So what
they're ashamed of it. Can I tell you?
What's that?
They feel like maybe I should have asked more questions. Maybe they feel ashamed. Some of them don't really understand that it's the wrong look, but many patients, they're just ashamed. They carry that with themselves the whole rest of their life.
Right, which is what makes me angry and why I'm sort of the person that I am. I kind of consider myself a little bit of a crusader because I love what we do, and the beauty and the danger of plastic surgery is that it can transform your life in any one of two directions, for the better or for the worse. And while we assume or hope that if you spend money and do homework, you're going to get a great result, the sad truth is that it doesn't happen all the time. And it actually seems to be, and I may be biased, that it is more shitty than it is good. So at any rate, that'll wrap up this episode. I'm sure Dr. Towfigh will join us again and again and again, because she's constantly digging in the plastic surgery wastebasket to see what kind of nonsense we're doing. At any rate, Sharon, thank you so much for joining us on this episode. As always, if you like this podcast, I assume you do because you're listening. We exist only because you're listening. I don't just do this in a vacuum. So I implore you to subscribe, download, and share our podcast. If you think this information is interesting or helpful, share it with friends. You never know who's going to do what and then later realize, God, shit, I didn't know you were going to have that done. So we really appreciate it. Lastly, and most importantly, go say something nice. Go write something nice about our show. We appreciate it. Till next time, signing off, Dr. Rahban. See you next week on Plastic Surgery Uncensored.